In this video, we're going to look at healthcare funding in Ontario. In Canada's federal system, our federal government transfers money to the provinces to help fund healthcare. That's called the Canadian Health Transfer. Provinces can also fund their healthcare systems through their own domestic tax base. So, let's use Ontario as an example. Each year, the federal government will give money through the Canadian Health Transfer to Ontario. For the fiscal year 25-26, that number was around $21 billion. From there, the province will turn around and fund individual hospitals. So that's how that funding arrangement works, from the federal government to the provinces and then to local hospitals. How does the province choose how much funding should be allocated to each hospital? Well, there's a formula, and it's called the Health-Based Allocation Model. Kind of complicated, but what it does is it looks at the expenses, the expected expenses of a given hospital and how they compare to the rest of the province. And so their share of expenses will give them a share of the provincial funding. Now, try and simplify it through an example. Hospitals are funded according to projected expenses. So we've got to look at how those are calculated. Typically, those are calculated based on expected service volumes and expected unit costs per procedures. For example, let's say for a particular procedure, let's call it the complicated medical procedure, the province might look at a given hospital based on their population, demographics. They might come up with a number of 1,000. They predict that one specific hospital will complete 1,000 of this specific procedure, complicated medical procedure. So that's step one, figure out the volume. Step two, what about the costs? Well, the province will start with average cost. They call it the base cost. And then from there, each hospital might have local adjustments for things like geography and the local population, specialization at the hospital, maybe it's a teaching hospital, or economies of scale. Maybe a hospital does a lot of those procedures and they're able to spread the fixed costs over more units. So from there, they're able to derive an expected unit cost. For our complicated medical procedure, let's say that's $300. So we've got our expected number of cases, 1,000 cases. Each one funded according to an expected cost of $300. So our funding block for this procedure would be $300,000. Seems straightforward enough. However, these are just projections. They aren't the actual cost or the actual volume. That's where things can get complicated. Let's say the projected volume number isn't correct. We might have projected that our hospital was going to complete 1,000 complicated medical procedures. But over the course of the year, it could be a lot more than that. It might even be double. So our hospital here, in this hypothetical example, is completing 2,000 complicated medical procedures, but they're only receiving funding for 1,000. So the hospital is left to make up that shortfall. What about costs? Well, the projected cost was based on assuming $300 for our complicated medical procedure. That's how much the province was giving the hospital, $300 per case. But some procedures require complicated medical devices. Complicated medical device in a procedure could cost $295. So of that $300 coming from the province, almost all of that is getting eaten up by the cost of one of the devices used in the procedure. It doesn't account for the healthcare professionals to complete that, to deliver care, the medical supplies, even feeding the patient. All those things would have to be eaten by the hospital. The provincial funding was not enough to cover that cost. So, put this picture together. We've got increased volumes, more procedures completed than the province was funding. Also, the amount of funding given by the province was not sufficient to cover the cost of the procedure. That leaves the hospital in a situation where they have an operational funding gap. They do not have enough money. They were not funded to the degree they need to be for the given volumes and the actual cost of the procedure. Now that's a big problem, but that's not the only problem. There are more. For example, the idea of funding envelopes. Let's say in our hospital, there are 3 buckets of funding. The province calls them, here in Ontario, envelopes. So there might be one that's designated for long-term care, another one for community health teams. Each one is sort of specific for a purpose. In our example, our hospital might have one envelope for basic medical procedures, another one for medium medical procedures, and a third one for complicated medical procedures. Our hospital might have some money left over. There could be a surplus from the basic and medium medical procedures. Maybe they're particularly efficient, maybe the volumes weren't what they were expected, but there's money left over. It's the complicated medical procedures, the one that's leaving a big hole in the budget. The hospital may want to take some of those surplus funds and direct them to the area where they're needed. The money that's left over from the basic and medium procedures, move them to complicated to help cover that funding shortfall. Well, that's not always an option. The province may reclaim unspent funds. So even though the hospital was efficient and was able to economize and save money, it's almost like they're being punished for that because that extra money is taken back by the province, still left with a giant hole in the budget from the complicated medical procedure. Now, this stuff isn't really exciting for many people. It doesn't gather a lot of headlines. Often when you see stories about hospital funding, it's things like high salaries earned by specialty surgeons or isolated instances of corruption. But the real challenge is the funding model itself. So just to recap, in Ontario, our healthcare system is funded largely from the Canadian Health Transfer from the federal government. From there, the province allocates money to hospitals based on a health-based allocation model. Big challenges with that because the formula doesn't accurately capture volumes or costs, leaving hospitals underfunded.